Hello, everybody. This is another edition of GYN ONC Garage. We're going to consider two treatment papers today. My name's Ed Pavlik. I'm in Lexington, Kentucky, and my collaborator is
Frank Lawton from London, United Kingdom.
Well, today's paper Frank is going to start off with, and we'll take it with really an expected smoothness. This paper, both papers we're considering today, appeared in the Journal of Clinical Oncology, and this paper is really on taxanes. Frank,
yeah.
why don't you begin?
Okay. I think this is an important paper for a number of reasons. You don't see too many randomized phase 3 trials with a surveillance or a no treatment arm. I think that's quite important. And it probably reflects the fact that first-line chemotherapy regimens, platinum, taxane containing in patients who've had optimal surgery, really, I don't think we're going to see great advances in response rates because they're already so high, response rates in the order of perhaps 80–85%. So I think that the oncology fraternity is actually looking more at maintaining these excellent responses with some sort of maintenance therapy. Maintenance therapy is not new. When I was writing my MD thesis in Birmingham in the early 1980s, one of the arms of one of the studies we're doing was a maintenance arm. And obviously maintenance, low-dose melphalan, low-dose chlorambucil are hardly new ideas, but this treatment is looking at taxanes, and this is essentially the endpoint that they want is improve overall survival. But in the paper, they have actually said that progression-free survival was also one of the endpoints. So this is patients who've attained a complete response clinically, radiologically, and CA125 after debulking primary surgery and platinum taxane therapy. I think it's quite a difficult study to complete. It took over 8 years, and the authors do understand that it's not easy, I think, to say to patients who've just reached the end of first-line chemotherapy to be told, well, we're now actually going to give you further chemotherapy to try to maintain this response, or we're going to stop treatment and see what happens. And I think that leaves patients in limbo. And the authors do say that during the study, they did actually change the way that the authors were recruiting patients to explain to them that whilst they were still having primary therapy, they may be randomized to a study of maintenance chemotherapy. Looking at the survival, it's quite interesting that there's no significant difference in what they were looking for, which was progression, which was overall survival. No difference whatsoever. Progression-free survival, there does seem to be a slight increase in progression-free survival for the patients treated in the taxane arm, although it's not great, and the p-value is 0.055. So they do say that there may be a slight improvement in progression-free survival. The toxicity, however, is quite interesting. Something like nearly 12% of patients on the one of the two taxane arms stopped treatment because of toxicity, and 8.3% in the other arm. And it's quite interesting that the neurotoxicity rates, even in the surveillance arm, were getting on for 1%. So clearly, I think this is clearly you're not going to have neurotoxicity on a surveillance arm. So this must be prolonged neurotoxicity from previous treatments. So we have a study looking at maintenance therapy, which really doesn't show any advantage whatsoever in maintenance therapy. And I think it'd be quite interesting to say to a patient, or when a patient asks about management of ovarian cancer, is there any data that suggests that I've had the best surgery? Well, we don't have randomized data, but we have a lot of data that says if you get no residual disease, then you're going to do well. Is there any data that shows that the first-line regimen I'm going to get is better than others? Well, there are lots and lots of studies, but on the other hand, there are some randomized studies that show no actual improvement with platinum-based chemotherapy. But here's one that you can say, what about if I don't have any treatment at all? Well, the median progression-free survival is over a year. And I think that's pretty impressive. And also, of course, if you've if you have recurrent disease after a year of no treatment, the chances are you're going to have a much better immune response or immune to be able to bear the chemotherapy. So I think this is an interesting paper. It shows that surveillance does have a role. Treatment at relapse is probably just as good as maintenance treatment. And I think for that reason, I think this is an important paper.
I couldn't agree with you more, Frank. It sort of seems that many times a comparison is not present that's adequate in a paper. And so with that surveillance group, the only thing you have to face is what you refer to as limbo, how you really walk into the room when you're doing this longer study and say to somebody, we really want to say that you can be in a group where we don't do anything. And one can wonder if you put on your critical hat, are you selecting for a type of person at that point who's going to be in the surveillance group who will easily accept it, or a person who won't cross over to a treatment group?
Yes.
Many of these people could have, and it may well be the treatment, the surveillance isn't as good as it looks in this paper because of the crossover type of effect. But nevertheless, those are just guesses by people, myself now being, overly critical perhaps of what could have been going on. At face value, I think it's a very applaudable effort, and that I think it'll lead to basically a new search for maintenance therapy, because that's where we're really at right now. And whether people like it or not, maybe maintenance therapy boils down to someone who's a caregiver saying, well, we've got to do something. Let's just do this, okay? Because that's something is what the patient wants. And I think now surveillance, emerges as good as the Taxanes here.
Yes, I think that's important, and I think it is going to be quite difficult, I think, for clinicians to sell that to patients, because they would expect to be treated. But I think the optimism is that, well, if we don't treat you and you have a progression-free survival of another year or so, and then you'll be in a much better clinical condition to withstand the side effects of further chemotherapy. I think that is an important aspect of the management, and patients should be made aware of this. And as you say, there will be patients who say, wow, right, I've had first-line chemotherapy, I'm feeling good, I want to stay good, and you think you can keep me well with no treatment at all for more than a year, I'll take that. I think that's a very good, very important paper from that point of view.
One of the nuances of this paper that you have to emphasize is that rather than starting with a group of people where recurrences begun, these are starting right when primary therapy has been completed with the Taxanes. And I think that's important. It's not biased by fighting an uphill battle against a recurrence that already been demonstrated.
Yes.
So, okay, well, let's pass on to a second paper, Frank. And this paper is a little bit different than what we've just considered, in the sense that what it is it's looking at for all comers a therapy, and that means that the therapy that they're talking about is one of the PARP inhibitors, and they're talking about a PARP inhibitor called Rucaparib. Now, this paper also has almost the same author group across the world that the first paper had that you talked about, and it's been very well done at multiple institutions. The thing that's different about this paper is it shows that there's a big benefit in starting with this PARP inhibitor called Rucaparib, and continuing therapy in terms of progression-free survival. This really means that you can merge primary therapy with continuing therapy, which would normally be called maintenance therapy. So this is a therapy that is perhaps a forever therapy without any switching in terms of how it's being presented right here today. The thing that's interesting about it to me is that the PARP inhibitors normally have a history of complications. And in this case, the complications that they report with Rucaparib are relatively minor. And that's really quite good in this paper. So, Frank, what do you think?
Yes, I agree. I think the data are interesting because it does appear to show this PARP inhibitor has a completely different, well, not mode of action, but a completely different response from the other PARP inhibitors to show this very important or very big difference in progression-free survival when other PARP inhibitor studies have not shown that. I think it's so either there's something strange about the patients that they've chosen, or this really is an improvement from both point of view of toxicity and for response and duration response over the other PARP inhibitors. The one thing I think that's going to be interesting is that are there any long-term side effects? Clearly, the short-term side effects are manageable and expected. But if we're going to be treating patients with low-dose, long-term maintenance therapy, we may be seeing side effects that don't appear for many, many months of treatment. But otherwise, I think this looks like an interesting PARP inhibitor and probably superior to the other ones that are being treated. The next paper should be this against placebo or this against surveillance and see what happens.
Right. And basically the next one too should be an extended interval so that survival can actually be examined.
Yeah. So, although so far very few papers have shown any improvement in overall survival. I don't think there's hardly any progression-free survival, but it doesn't translate into improvements in overall survival.
I will point out one thing about the paper is that residual disease was included for all comers, whether you had residual disease or minimal residual disease, and so actually maybe in breaking follow-up studies down to people with minimal residual disease or no residual disease versus those with residual disease. The results will be different, but right now these results look promising.
Yes, indeed they do. Yes, I agree entirely, and presumably quite expensive as well. I don't know what the cost in improvement is, but I suspect it will be quite considerable for these drugs.
Absolutely. Well, this cost problem, is a little bit like the military problem. You get to a point where cost erodes how many jet fighters you can buy, and you become a weaker military. And I think the same thing is true as the cost continues to increase for some of these anti-cancer agents. You will reduce the candidate population for being able to purchase, the drugs, or for their insurers, or for their national health services to approve them.
I think one of the other interesting things is in this study is that a lot of studies of PARP inhibitors, whatever, will find a subset of patients that say, well, here is a group that seemed to do well, and this requires further study. And I think in this paper, as you said, they've really taken all comers. They've taken, they haven't they've broken down by residual disease, but as you say, it doesn't matter. They've used patients who are all sorts of clinical situations. And I think it's shown its true worth. This looks like something interesting and superior to the other PARP inhibitors, both from response and from toxicity data, I think.
Absolutely. Well, Frank, that wraps it up for us today. It's good to see you. We'll look forward to doing this again next month.
Indeed, we will. Okay. Cheers, Ed. Thank you.